Okay, so this is a case I did about a month ago, 56, chronic right lumbar, paralumbar buttock pain for about almost 10 years, more than 10 years. Very progressively worse, trouble standing, sitting, walking better with supine, some blocks of facets and foramen over time that helped, but didn't last. So we went ahead and fixed her. Go ahead and show the x-rays. So I actually showed this case at our weekly conference because I was conflicted about what to do with her. But the apex of her curve is 3-4. She has nasty facets at 3-4, and she has a, let's call it a snug, but not squashed foramen on the symptomatic side at 3-4. Next slide. And that gives a little peek at the foramen. You see the nerve being contact there. Next slide. And you can just go through the cuts and you get a sense that one to the right reveals the foramen. Next slide. Those are lower. So go ahead. And those are the facets at that level, which I don't know if that would disqualify the patient from this procedure or not, because I think it was a combination of foramen and facet disease that might have been her pain generator based on injection response and exam. Next slide. So more of the same. Next slide. Keep going. Yeah. All right. Next slide. You get the idea. Just go to the end. So I did her as a lateral, and I was planning on doing a standalone lateral. Normally my cage is a little more centered to posteriorly placed. This one was a little bit to the front, maybe because of a rotation. So I decided to, this was the Globus. I just backed it up with perk screws using the robotics. And she's had a nice response. She's about a month or so out, and she's reasonably high. You can see we got a nice elevation of that foramen in that view compared to the pre-op. And the lateral shows similar. So, you know, I think if I were thinking about this intradiscal or intravertebral device, from the femoral standpoint, I would consider it. From the facet standpoint, I might be worried. So I guess that's a point for discussion. But otherwise, you know, I think this is a potential kind of patient that could be helped by this procedure.
Oh, excellent case, Sean. Venkat has a question, and that is that perhaps you can answer any of the other panelists, is will hypermobility at the disc space, and you have some lateral listhesis, I think, in your case there, will hypermobility be viewed as a contraindication to the VBO, to the intravertebral body? Your thought?
Yeah, I mean, that's a good question. You know, the lateral listhesis, the old listhesis, as we call it, has often been identified in and of itself as the pain generator. So, you know, I'm a believer that a lot of these T10 to pelvises could be done by an apical one-level fusion. And I've done that over the years a fair amount. But I do think lateral listhesis is concerning, and especially if you press on their back and at that level, you get a very discrete pain response. I think that can confirm it. I don't know. You know, these lateral listheses oftentimes remain stable over the years as well. This isn't a terribly bad one, and our disc space is pretty narrow, so it's not like it's sliding all over the place, but I guess that's a valid question.
And it's interesting, a lot of our colleagues would do a T10 to pelvis on this, and you know, really did a focal procedure, sort of the just percutaneous pedicle screws with the robot in the back. And initially we were going to do a standalone lateral cage. So I think it's very much a different way of looking at this. And, you know, I'm sure in your discussions with the patient, you get into possible scenarios and the need for maybe more surgery, but I think I can address your pain with this. It might be interesting to hear what you have to say to the patient. And one other point is if you had the foundation surgical device that has the lateral plate, would you have considered just plating this from the side and foregoing the pedicle screws?
Well, in this particular case, I mean, I do believe in the standalone lateral. I've done it for years. And like the other fellow who presented his 1-year follow-up, I agree with them. I've done a lot of standalones over the years, and they've done well without one screw or two. But in this particular case, I think because of her deformity and the slightly anterior placement of the cage, which isn't typical for me, I would have felt more secure maybe with the technique that Randy has and not backed it up. That would have given me a little bit more assurance, I think.
Julia has his hand up there, and Ed.
Yeah, I think, that I have utilized this method before. If I'm in doubt which level is going to be symptomatic, or maybe Dr. Betts, if somebody wants to see if the problem is coming from the facet or the disc, or, versus using this intraosteotomy device, is to get a CT SPECT to see if they're lighting up. If they are not lighting up on the nuclear medicine SPECT, then I think, we can do this interventional osteotomy device. So
I think that's a
good
great point. Great point. That's probably other than, I've been, it's an extremely common study that I've been ordering over the last 2 years. I really think it's been a big value add to my practice and my patients, just trying to understand what is their back pain generator. And if I target those hot SPECT regions, I feel like my success rate in getting back pain to stop is significantly higher than it would be otherwise.
We have some technology. I don't know if you all have this or not, where they'll map geographically the SPECT onto a CAT scan. Do you guys have that?
Yeah, it's
So
fantastic.
it's not just the SPECT. They'll overlay it onto the CT, and it's nice. It's very nice actually to have that.
Yeah.
Excellent case. All right, let's go to the next case so we can get through them all. I guess this is mine. So this is a 67-year-old lady. She's a government worker in upstate New York, but she also likes to chop her own firewood with an axe. So not a chainsaw. She's a very active lady, and looks 10 years younger. She has a history of osteopenia. She has taken alendronate in the past, but presents with progressive back pain and deformity, and now new onset of of a left lower extremity sciatica. She's been treated non-operatively, and she has a normal neuro exam. So I did use the DEXA score here, but I would very much agree with the Hounsfield units being very valuable. But she's osteopenic. I look at all the numbers and not too terrible. So let's go to the next slide. So this is her. She's had this adolescent onset scoliosis, but it's getting worse. And now she's starting, because of this lateral listhesis here at 3-4 and this fractional curve, she's got some foraminal stenosis and developing left leg pain, a little bit of a lateral listhesis here, and pretty good sagittal alignment. The fractional curve is somewhat flexible. The index curve is pretty flexible as well. And foraminal cuts, you can see some lateral recess stenosis at L3-4, maybe some foraminal stenosis at L4-5. And I think a lot of this is from the fractional curve below the index curve. And you can see some of the foraminal narrowing here, particularly at 4-5 on the left. So, I won't belabor all of this, but, does she just need a focal decompression and fusion in the lumbosacral region to address the sciatica? Should she have a decompression and fusion of the entire curve, T10 to sacrum? Can we do something more focal, inner body, plus or minus posterior, or what other options are there? So those are the sort of questions. I'm a quotes deformity guy. I do a lot of idiopathic scoliosis surgery, not as much in the way of degenerative pathology, but adolescent onset. So my mindset tends to be to correct the deformity. But she's got a lot of leg pain. Neurologic exam is normal though. So this is what we did today. we did an apical fusion at L12. And Dr. McCance was on the case today with me. We did this together. So we did an apical fusion, L12, and then we tethered across the rest of this with dual row screws across the majority of segments, and then single at 4 and T11. So T11 to L4. This is very much an off-label approach. It's a motion sparing but apical fusion procedure. I've done a few of these now, quite a few, I would say. And because you're correcting the fractional curve, the leg pain goes away. And that persists for years, at least in the cases I have. We don't have a prospective study. We haven't published it, although we do have a case report on a lady that I operated on when she was 43 and now is 50. That's published in JBJS Case Connect. So the lumbosacral fractional curve and the sciatica related to that seems to resolve by correcting the deformity above. There's also some data that suggests if you do an interbody fusion, an apical fusion, it takes some of the stress and strain off the tether. And with a dual row and a 67-year-old lady, this may stand the test of time. Even if it breaks, it may still largely hold. So for me, I'm very much interested in the vertebral body osteotomy. Maybe not for this patient so much, but for similar patients with newer iterations of the VBO, to try to do less of the interbody fusion and maybe address wedged vertebra at 2 or so apical levels, and perhaps even tether across it. I think that's going to be a fascinating area, and certainly one that I'm interested in, but I'll have some trepidation. I look forward to seeing Michael get those couple of cases done and show those to us in the next webinar, because I think that's going to be a really great telltale if he can decompress the nerves and get that to heal up. And Randy has a series of, Randy, was it 15 cases that you published, or was it more?
14.
14 cases 20 years ago in Spine Journal, and where he did just that, VBOs at multiple levels in neuromuscular scoliosis and paralytic scoliosis patients, and had some very satisfactory outcomes in a good majority of them. So maybe, Randy, you could speak to that.
Yeah, they're published, and we proved that technically you could do it. That at that time we didn't have a tether, so we had to use a rod, and took the rod out at 12 weeks. That's why I know they heal. And then proved with bending x-rays that they maintained a good range of motion. So if anybody wants those references, please let us know. Happy to share them with you. 2 published articles on it.